I'd like to thank everybody for joining us for this evening, and I hope to be able to impart, some information about the hip and knee joint replacements, what's involved, and what it can do for you, especially for those who have painful hips and knees that need joint replacement or other treatment. So how the hip works is that it's first one of the body's largest weight-bearing joints, and it's basically a ball and socket joint, where the ball part here is a part of the femur, and the socket part is part of the pelvis. And it's supported by a number of muscles, tendons, and ligaments that help to move the joint in a smooth manner. And it's if it's a normal joint, it works very well, and it moves without pain. The other joint that we're concerned about is the knee. It's also one of the body's largest weight-bearing joints. It's formed by the end of the femur and the tibia and the patella, or the kneecap. Again, it's also supported by ligaments, muscle, and tendon. And there's also a meniscus in between the femur and the tibia. And again, if everything is all normal and healthy, it acts as a normal joint, like a hinge, where it's responsible for a variety of motions that will enable us to walk, go up and down steps, squat or sit down or kneel. And again, if everything is normal and works normally, it moves smoothly and without pain. So a healthy hip or knee joint normally has, normal cartilage, which allows for smooth and a stable movement between the ball and the socket of the hip in the hip joint, and between the joint surfaces of the knee and the knee joint. And when these are all normal, motion and weight bearing is possible without pain. But then again, there are some situations where we may have pain in the hip or knee, especially when we have a damaged hip or knee joint. And this can occur if somebody has worn out cartilage or inflammation in the joint, or you have a broken bone from trauma or injury, or necrosis, which is the destruction of the bone when you have a reduced blood supply to it. And the end result is the loss of mobility and the development of pain. So when you have worn out the cartilage in the knee joint, the cartilage and the meniscus is similar to the brake pads, in a car, as an example. And over time, they can wear out, and you lose that smooth surface of the joint. And when you try to move your joint, you can have cracking motion in the hip or knee. As you can see in the hip here, you have the normal joint on the left and a joint on the right that has worn out cartilage. So you would expect movement to be affected. You can also have inflammation of the joint if somebody has rheumatoid arthritis or any other form of inflammatory arthritis, like gout, for example. And in the healthy joint, the joint looks normal. You have normal joint fluid, and it's not swollen. But if you have an inflamed joint, you have a lot of swelling in the joint, and that fluid has inflammatory substances that can ruin the joint or even the bone. And that can also cause wear in the cartilage and makes the cartilage surface rough. A broken bone, especially in the hip, can cause some problems with bearing weight on it. And at times, it can also affect the health of the cartilage in such a way that you develop arthritis by just having a broken bone. This is an example of a hip joint that has lost its blood supply. Sometimes it can happen on its own, but a lot of times it can happen just from trauma, like a broken hip. And so the ball part of the joint deteriorates, and it becomes flattened out. It's not smooth and round anymore, and affects motion in such a way that it can be painful. So again, the end result of all of this, when they happen, when you have abnormal structure in your joints, it can cause pain, loss of mobility, and discomfort that it affects your quality of life. Now, how do we treat these conditions in the hip or knee? Well, it goes from the very simple rest, you just offload your hip or knee, and that can help with the pain. You can also use ice or heat, depending on how acute the injury is or the pain is. Usually the early or acute pain is usually managed by using cold packs or ice. And the more chronic or long-term pain, you can either manage with heat or ice. You can also modify your activities, which means if it hurts, then you just rest or reduce the amount of load on your joint. You can also use a cane or crutches in order to reduce the weight on your legs or on your joints. Sometimes your doctor can prescribe a medication, or there are over-the-counter medications that are available that can help with pain. These can be in the form of anti-inflammatories or even analgesics, like Tylenol and similar medications. Even lidocaine patches or even ointments can be considered as medications that can help to manage your pain. Now, physical therapy or any type of therapy or exercise is beneficial to your joints, and especially if you have joint pain, because it helps to support your joints if you have stronger muscles, because the instability from weakness can actually make your joint pain worse. And so doing exercises, even though some would think that this can be painful for the joint, if done in the right way, it can actually help for pain control. Now, when you have joint pain, sometimes that can be due to excess weight on your joint. And so you can imagine, especially for wear and tear, a type of arthritis, the more weight you have on your joint, the more pressure there is on it. So it would be beneficial to also watch your weight, make sure it's a healthy weight. And there are some ways that you can obtain help in order to manage any weight issues. Other more invasive ways to manage joint pain could be injections, which can be in the form of steroid injections, or there's a gel injection called hyaluronic acid. And that is something that we can do in the office. Physicians that are trained in doing these injections are available, and they can also be effective, but it's expected that the effects can be for the most part short term. In some cases, they can last longer than 3 months, but in most cases, that's what we expect in terms of their length of effect. There are other injections on the market and in the medical practice that can also be used, but they're not very common. Some types of injections can sometimes use stem cells, but as for now, those are all considered experimental. And when these treatments don't work, all the conservative treatments, then it may be time for surgery. And surgery is in the form of a hip replacement or a knee replacement, depending on the joint that is bothering you. Now, the question is the joint replacement surgery right for you? Well, The first step when you make the decision about having a joint replacement is to meet with your surgeon to see if you're a candidate for the surgery. Your surgeon will take your medical history and perform a physical examination. They can get imaging in the form of X-rays, CT scan, or MRI that will be used to determine if there is an issue with your joint. If the pain is significant and the X-rays show advanced arthritis of the joint, then you could be a candidate for surgery if all the other treatment options, the non-operative treatment options, have already been exhausted. And the decision to move forward with surgery, sometimes it's not always straightforward, but it really helps if you have a discussion with your physician as to what would be the best course of action is. So again, doing a physical examination is important, getting the medical exam, getting the X-rays. Again, here, you're showing advanced arthritis in the X-ray here. So this might be a situation where surgery would be a viable option for you. Now, let's say you make the decision now to do a joint replacement. There are some things you need to do in order to prepare for the joint replacement surgery, and that includes medical clearance as well as dental clearance, because addressing any medical or dental issues will improve the healing and reduce the complications after a joint replacement. It's also very helpful if you practice the exercises prior to the surgery, because it makes it easier to perform the exercises afterwards. And exercises after the surgery is very important in order to make your joint functional, as well as help to reduce pain and hasten your recovery from the surgery. Home preparation is also advisable, such as getting rid of rugs that you may slip on at home, getting your, let's say you have a 2-story house and you need to set up a bedroom or a place to sleep on the first floor. Those simple things just to get yourself ready to recover after the surgery, especially if you expect to be going home afterwards. And the joint replacement procedure, what to expect on the day of surgery. Usually you arrive an hour and a half to 2 hours prior to the planned surgical schedule. It's similar to going to an airport. You have your boarding procedure, so you have to be there a little bit early. So things that need to be checked on, there's a checklist that need to be done in order to get you ready for surgery. You should be fasting after midnight, which is important for anesthesia. And the anesthesia service will discuss the options with you on the type of intraoperative anesthesia to use. And this can be in the form of general anesthesia or spinal anesthesia, whichever you are comfortable with and what is advisable for you at that time. You may be given a medication to reduce anxiety and reduce the incidence of nausea on the day of surgery. And your chart will be reviewed to ensure that all the necessary tests and clearances and your labs look good before you have the surgery done. And antibiotics are also given on the day of surgery and also afterwards in order to reduce the risk of infection. Now, let's go to the details of the actual surgical procedures. When you have a hip replacement surgery, there are different approaches. You might have seen this being discussed if you are researching about hip replacement, about the anterior approach, but there are also other hip replacement procedures that use a different approach, such as the posterior or the lateral. But the approaches, even though they're different, the procedure for doing a hip replacement is basically the same. First, the damaged femoral head or the ball part of the joint is removed. So that's basically the ball part of the ball and socket joint. And The socket or the cup in the pelvis is prepared by reaming, and the new cup is attached. A stem, a metal stem, is placed in the femur, and then a ball, which could be metal or ceramic, is attached to the metal stem in the femur, and that completes your hip joint components. So it basically looks like this. So there are several components there. There's also a plastic component in most cases, and so even though there are different manufacturers of these hip replacement components, they basically are constructed the same, with just minor variations. And this is what the full hip replacement would look like afterwards. And this is what it would look like on X-ray. Okay. Now, for a knee replacement procedure, there's basically only one approach, which is from the front. So the knee joint is exposed, and the diseased cartilage is removed by making bone cuts from the femur and the tibia. It's basically capping of the bone is what the knee replacement procedure is. So basically a resurfacing procedure. So the bone is resurfaced with metal and plastic components. The kneecap is preserved, or it can be replaced. In this diagram here, there's a patellar component, which is a plastic liner that goes on the patella or the kneecap. In a lot of cases now, the kneecap is preserved, and it doesn't need a plastic liner. And that's on a case-to-case basis, depending on how much degeneration there is in the kneecap. But for the most part, this is the diagram that shows you a full knee replacement. The picture on the very left will show you an arthritic knee joint, and on the right side of it is after the joint surface is replaced. So that's what a knee replacement would look like. Here at Guthrie, we offer robotic assisted joint replacement. We also do these joint replacements manually. It all depends on what your insurance will authorize or what is actually the better procedure for you. The navigation and robotics tools that we have are very helpful for making precise cuts, balancing of ligaments, as well as placement of the implants. And this can be done for anybody who needs a hip or knee joint replacement, as long as it's appropriate for you. This is what the robot will look like. The robot is not actually doing the surgery. The surgeon still does that. And this is just used as a tool to make the cuts more precise. Now, recovering after a hip or knee joint replacement, usually get post-operative antibiotics. You'll be put on a blood thinner because that's one of the potential complications after a joint replacement is the development of blood clots. A good way, or one of the best ways to reduce the risk of blood clots, is actually mobility. And that's where physical and occupational therapy comes in to help you mobilize, get in and out of bed, and start walking. At times you can actually start getting up and walking on the day of surgery, or at least the following morning. Pain control will be provided because this can be an uncomfortable procedure since it's a major surgery. But there will be a plan in place in order to help control your pain afterwards. Expect to be in the hospital 1 to 3 days. Nowadays, the length of stay is getting less and less as the care has been more tweaked in terms of getting you better pain control, as well as getting you to recover faster from the surgery. There will be the availability of case management or a social worker for your discharge needs, whether if you need to go home or need to go to a rehab service. And there will be appointments that will be made for your follow-up in the orthopedic clinic, so as to monitor your progress with your wound healing and to monitor your implants with X-rays afterwards. So, there are some questions that are usually very common about, what to expect after a joint replacement. How long do they last? How much pain will there be? And how long does it take to recover? Everybody's different, but in most cases, it may take 6 weeks to 3 months to recover from a knee replacement. It depends on your preparation and how active you were prior to the surgery. The more active you are, more prepared you are, and the more that your medical issues have been addressed prior to the surgery, the quicker the recovery that is possible after the surgery. And so, I'm gonna leave it up to the question and answer portion if you have any other questions, but some of these expectations would be a good one to discuss with your surgeon because they can vary depending on your particular situation. And so this is the end of my talk, and I'd like to thank everybody for listening, and we'll open up the floor for questions. All right, so I think there's one here that I see. There's a question about explaining anterior versus posterior hip surgery. So the difference between an anterior and posterior hip surgery would be where the incision is, for one. So as you can imagine, the posterior hip surgery means the incision will be more on the backside of the buttocks, and it's actually one of the most common approaches for total hip surgery. And the difference is that for a posterior hip approach, the hip is covered by a capsule, and that is the part of the hip that is being accessed. It involves also separation of some of the muscles on the buttocks, and it's a very effective way to approach the hip joint for a hip replacement surgery. Now, the anterior approach, as you can imagine from the name, it's accessed from the front part of the hip, so basically close to the groin. It's on the outside part of the groin, and one of its features is that you avoid separating the muscles in the back of the hip, which can sometimes be an issue with the risk for hip dislocation. And so this approach actually opens up the front part of the capsule of the hip, and it's sometimes called a muscle sparing approach. Now, we have some surgeons who are trained in that approach. It has its advantages. It also has its disadvantages, as it has some nerves in the front that can be affected. So, but the approach that is used is not as important as compared to as related to the technical expertise of the surgeon in choosing which type of approach. Because whether you do it from the anterior or the posterior, each one has its drawbacks, each one has its advantages, but you would want to have somebody very comfortable with whatever approach they're using. So mainly it's the approaches are just based on what part of the hip is being opened up and where the incision is. The lateral approach that I mentioned in the talk, it means exactly what it means. It's in between the anterior and the posterior, so it's on the side of the hip, but it's still technically an anterior approach. So if you want to also know what the lateral approach is. There's
Dr. Tayag,
yes.
Of the three, which one do you think you probably perform the most often?
Myself, I do the lateral approach. It's
So in between.
in between. It's further from the groin, so it avoids the nerve in front. So there are some cases where the anterior approach can affect the nerve by the femur. It avoids that. It also avoids the posterior um, structures like the sciatic nerve. So it's basically a nerve-friendly approach, and it has really good exposure. Um, I do the other approaches actually for different types of surgeries, not joint replacements, but those are also approaches that most everybody know. But it just depends on how how you were trained during your training as to what approach to use and whatever you feel most comfortable with.
Great. We've got another question here about rapid recovery with the lateral approach. Could you talk a little bit about that?
So they talk about the rapid recovery with the anterior approach. So one advantage of the anterior approach is because it's considered muscle sparing. So the walking speed for the anterior approach approaches its peak earlier compared to the other approaches, as early as 2 to 3 weeks. But at 6 weeks, the peak walking speed is actually the same for all approaches. So it's more of how quickly you recover from the surgery that is the advantage of basically the anterior approach.
Gotcha. We also have a question here about the Mako robotic surgery for knee replacement. I know, it's kind of just surgeon's preference, really. But could you talk a little bit about Mako and why you like to use Mako?
So with the Mako robotic assisted navigation, so for knee replacements, if we do them manually, we used these cutting guides. And so, sometimes the cutting guides can shift or move, but in most cases they're very stable. The One of the main advantages of doing the Mako is that when you do a cut, you only do it once because you've already fine-tuned the position of the cut. With the cutting guides, we may have to do it once or twice, mainly to help with the balancing of the knee joint. So it's very helpful with knee joint surgeries, mainly because it helps to speed up the surgery, and also it helps to balance the ligaments a little bit quicker. But either way, whether you do the robotic surgery or you do the surgery robotically, or if you do it manually, you can still get a good alignment as long as you're very familiar with the instruments. But I have shifted a lot of my surgeries with the Mako only because it allows me to do the cuts more precisely and with less repeat cuts. Also, the placement of the implants is a lot easier too, because the sensors will help us to locate the exact rotation of the implants that will help with making your knee a more balanced knee. Now with the hips, the main use for the Mako is for the reaming, and again it speeds up the process too. As if you use the robot for reaming, you only ream once. When you do it manually, you do 4 or 5 reamings just to get to the depth that you need to use. So it reduces the time that we do the surgery, and that's why we like it. And less time for surgery is also good for the patient, because that means lesser time for surgical exposure. So it's a
Right.
good tool.
What would be some of the reasons that you would choose not to use robotic assisted surgery and you would do it manually instead?
Um, there are times that we can't use the robot if we can't attach the sensors properly. And that could be a function of, the size of the limb, because the the pins that we use can only go up to a certain length. So that would be one of the main reasons. Um, the um, the other thing is if you have a previous implant in the hip, let's say you had a hip fracture that was fixed with a plate or a nail, it may not be possible to use the robot for that. So when we do a procedure in this type of situation, we actually have to do it with the assistance of X-ray while we do the hip replacement. So that would be one of the reasons for it. For the knee, I can't really think of any other reason not to use the robot except for if your insurance does not authorize it.
So when possible, you prefer to use the robotic assisted surgery?
Yeah.
Gotcha. All right. Couple more questions here. How long do hip replacements typically last? The example here, we've got someone who's 50 years old and wants to be active, and they're asking if it'll last until they're about 80 or 85.
Just from experience, and this hip was made 25 years ago, and so we just recently revised it. So I would imagine it can last that long, 20 to 25 years. The main component of an artificial joint that wears out would be the plastic liner, because that's the one that would be the part that can wear out. Metal usually stays very much intact forever, but it's the liner that's going to wear out more.
So in about 20, 25 years, do you go back in?
25 years, yeah. They would mention that, for each year, there's a 0.5% chance that you may need a revision. So, even though we say it can last 20, 25 years, there's still every year a chance that you might have to revise your joint. But that's just more of a risk of something happening that might not necessarily from wear or tear, but it's more of a risk depending on, let's say, you may get an infection or you may get some loosening. Your ligaments may not be as tight as before. So those are different factors, but expect that each year there's a 0.5% chance that you might need to revise the hip or knee. And each year it's cumulative. So let's say the first year is 0.5%, the second year is 1%, third year is 1.5%, and so on. So it's all a function of time. That means the longer that the joint has been there, the higher the chance that you might need a revision for that amount of time.
Right. Good to know.
Yeah.
Another question here, this one's a little specific, but might apply to a couple other people. They ask, is it advisable to have knee replacement if you are diagnosed with bone on bone, but aren't feeling any significant pain?
Oh, so that's actually a very good question. The main reason for doing a joint replacement is because of the pain and the disability that goes with it. So if you are not having any pain and are moving well, even if your x-rays are showing really bad arthritis, it is not a good reason to do a joint replacement. And we've actually seen that. We see somebody that has very bad knees on x-ray, and we only saw it just because they have an issue with the other joint, and then the other joint actually looks worse. The joint that looks worse is not painful at all. And, if it's not painful, I would not recommend replacing it just because of how it looks on X-ray. On the converse of that, somebody has a very painful joint and X-rays look normal. That can also happen. In those cases, we really try to pinpoint what the actual source of pain is. And if everything else is exhausted, even with the normal looking X-ray in a joint, those can be actually the better candidates for a joint replacement.
Interesting. Wow. So another question we have here, I know you mentioned that you put your patients on blood thinners because that's one of the risks. How long do patients typically stay on those blood thinners?
So typically 2 to 3 weeks of the, these medications, these blood thinners called DOACs. So those are the typically Xarelto or Eliquis or similar blood thinners. If they put you on Lovenox, same thing, 2 to 3 weeks. But sometimes they use aspirin, which is recommended to be used 6 weeks. So it depends too on the type of blood thinner.
Gotcha.
Yeah, but at a
So they should
2 to 3 weeks.
Right, and their surgeon will, specifically tell them
Yeah.
how long.
Your medical history will actually help to guide us on what blood thinner to use.
Good to know. Thank you. Another question here about knee replacement, but I think it could probably apply to hip replacement as well. Is it normal to have fluid draining after surgery?
Yes, especially in the knees. So with the knee joint, your knee joint is covered by a capsule that has a membrane on the inside called the synovium. So the synovium is responsible for producing the joint fluid in the knee joint. And that is actually not replaced. It's always there. It's a normal part of your joint. And that's the part that can get irritated and produce the fluid when you have arthritis or any inflammation in the knee. So even after surgery, we do remove a part of your synovium during the surgery, but it grows back. There's really no way to stop it from doing that. The hope is, the theory is if your knee joint is normalized, like your joint surface is now smooth, the idea is that there's less irritation in your knee, and so the irritation to the synovium would also be less. But sometimes that's not the case. So you can be also, you may have some type of inflammatory arthritis at the same time, and that's why the joint fluid is still there even after a joint replacement.
Gotcha. Our next question, does the body ever reject the artificial joint? And if so, what do you do about that?
Yeah, so if you have specific metal allergies, that would be the main reason as to why your body will reject it. If you do have a metal allergy, it's very important to know that. And one way to address that is to actually order specific implants that are made of a material called oxinium, and it's a very specific implant. So that would be actually good to know when you have a discussion with your surgeon. Make sure to let them know that you have a metal allergy, and you'll have to undergo metal allergy testing prior to the surgery.
Do all patients go through the metal allergy testing?
Actually, no. Even if somebody's allergic to nickel, the amount of nickel in the implant is so minimal that it doesn't really produce a lot of reaction. But we still want to play it safe and just order the oxynium components for these patients that really have a true metal allergy.
Right. Good to know that that's an option. Let's see. So what would you say is your typical return to work time frame? So for office workers, someone who works at a desk, or for someone who does a more physical job?
Yeah, so for for returning to work, again, that's dependent on comfort. I would not advise at least within the first 2 weeks. After 2 weeks, you can have a discussion on what your comfort level is. Desk work, probably after 2 weeks would be reasonable. It also depends, let's say you drive to work and it's your right leg that was done, in a knee replacement. The concern there is the reaction time for you to hit the brakes or to operate the vehicle. If your left leg was the surgical leg, you can always operate with the right leg without any problem. So it's a case-to-case basis. But if that's your situation, 2 weeks for sedentary work would be fine. But for those who require a lot of walking for work, let's say you do a lot of walking. I think I had somebody who was a surveyor, so they had to, do a lot of walking. It was at least 6 weeks before getting back to work.
So it really varies then.
Yeah. So it's also job specific. So
right. And then let's see. Looks like this is our last question. It's kind of an interesting one in my opinion. So when you do a knee replacement surgery, do you also clean out the calcium deposits that are associated with arthritis, or is that not the same procedure?
So they're probably talking about bone spurs, and also these calcium deposits on the meniscus, which you see on X-ray actually. So yes, those are actually taken out because they can affect the balancing of the knee. Now there are calcium deposits that are on the tendons. Those are usually left alone because we don't really have to take them out at that point. Even if we do, that means that you have some issues with your tendons and ligaments that are causing them to have these calcium deposits, like tendinitis or ligament sprains, as an example. So the surgery actually does not really help them in terms of if you try to take out those deposits. But if the deposits are in the joint and on the joint surface and on the bone, we usually take them out so that they don't interfere with the placement of implants. You may still have some of them left after the surgery if they are deeply embedded, like in the soft tissues. But yeah, we take them out if they interfere with implant placement.
And I know I said that was our last question, but we actually got one more that I think a lot of people will be interested to hear. Stairs with hip and knee replacements. Talk a little bit about that. Do you recommend stairs? You mentioned setting up maybe a bedroom downstairs.
Setting up a bedroom downstairs just makes it easier for you. So it just reduces your load, at least for the first couple of weeks. But once you get more comfortable, it's okay to do stairs. Physical therapy will actually train you on how to use stairs properly if you have them. And there are exercises that they're going to have you do on stairs anyway, like doing a step up to help with your hip and knee strength. So having stairs and using them is not a problem. It's just based on your comfort. But we do expect you to be able to handle stairs after having a hip or knee replacement done. It's usually more difficult for those with knee replacements, though, to be able to handle stairs just because of the way that you have to put your leg up or down on the steps. So it may take a little bit longer for those with knee replacements to be able to manage stairs. And sometimes, you may have to do some modification on how you have to go up and down stairs if you have a knee replacement.
Usually temporarily, though, right?
It's usually temporary, yeah.
Right.
Very rarely that patients will have a problem afterwards in using stairs. But it can be an issue sometimes.
Right. Well, I think a lot of people will be happy to hear that you said stairs eventually hopefully won't be a problem, because I'm sure that's something a lot of people struggle with.
Oh yeah. Mm-hmm. Yeah. As long as it helps to work with physical therapy on that, because they can really help a lot in helping you strengthen your muscles, and that's the most important part after joint replacement is actually the therapy. So it's highly recommended that you continue with your home exercises even after you're done with your physical therapy sessions.
Do you ever recommend prehabilitation? So
Yeah.
physical therapy before?
Yes, it doesn't have to be formal physical therapy. We do have a book on the exercises, and I believe I may have to check on that. The rehab department here may have like some YouTube videos available for the exercises, so that you can do them prior to the surgery. You may want to reserve most of your or all of your physical therapy sessions after the surgery, so that you can make the most out of the rehab sessions. Because sometimes your insurance may only allow a certain number of visits for physical therapy.
That makes sense. All righty. Well, I guess that's the end of our Q&A session, and that also marks the end of tonight's seminar. So thank you so much again to Dr. Tayag for sharing your presentation with us. And thank you to our audience who took the time to join us tonight. Really hope this was helpful for everyone. And keep an eye out for an email from us sometime over the next week or so. Like I said, in that email will be a recording of this event, a survey where you can provide us with some feedback, and of course, a link where you can schedule an appointment online with Dr. Tayag. All right, everyone, I hope everyone enjoys the rest of the night. Thank you.
All right, thank you.